believe there have been two major changes when it comes to a pulmonologist's practice with regards to COVID-19. First is I think all of us have witnessed a very steep downfall in the number of patients who are coming to us. So I think that is going to change in the coming few days. But then what we are now left with is dealing with the same number of patients, but in a very different way. Very great emphasis will be given on disinfection, which I think should have been the cornerstone always. But with COVID-19, now we are getting all the more sensitive, all the more judicious as to how we utilize our resources. So first thing I believe is, as the guidelines have said, spirometry is now only and only recommended in specific cases, patients who are pre-operative, patients who are posted for lung transplant, any patients undergoing chemotherapy. So these are very limited indications that we are left with spirometry. Second thing is the requirements that come along while performing a spirometry, the requirement for a negative pressure room, a specific disinfection protocol. These might not be possible for each and every center. So one of the recommendations that have come from the Cleveland Clinic paper is that we might have to consolidate testing. So there will be limited centers which would be performing spirometry, centers which can provide proper PPE to the technician, which have a designated spirometry room where the ventilation or the exhaust is not going out to other part of the hospital area. We are still advised to manage patients virtually. So even now, as much as possible, we should manage our patients virtually. If we can go ahead with treatment protocols with online consultation rather than patients coming up to our OPDs, maybe crowding in our OPD, and our OPD now becoming a source of cross infection. So these are the various difficulties I believe all of us are facing when it comes to spirometry in specific. See, I believe there is one blanket rule for all pulmonary function tests, which is you should defer all routine tests. Because eventually most of these procedures are aerosol inducing, and you go this way or that way, what you're doing is you're exposing the patient and to the patient who's coming in next, and your healthcare worker, your staff, and the machinery to a chance of contracting COVID-19. So for all the tests, there have been minor changes with how you can perform a DLCO and all, but I believe for most of the centers we should defer routine testing for the next few months. So see, right now we have specific recommendations from GINA and a lot of papers which are stating as to how to go about managing a patient of asthma. So the first point here is that your treatment for asthma stays the same. A lot of patients might come up with a query that the corticosteroids might lead to higher chances of contracting the viral infection. So that is not the case over here. On the contrary, if they anyway stop their medication, there is a higher chance of them landing up in an exacerbation, coming to the hospital, and thus getting infected. I believe something that has been very basic to asthma management but has been very underutilized, which is the asthma action plan, is something which would be the cornerstone in treatment of asthma during such time. Because what you need now is your patient to understand his symptoms and his lung functions better than what he used to always come to you in your OPD, and you used to give a prognostic recommendation as to whether we should step up or step down. So first what we see is that the patient should have a good asthma action plan wherein he or she is charting her own symptoms, if possible can chart his or her own PFR readings, and then they know what to do when they land up in an exacerbation, what doses need to be increased, and what is the action that they need to go ahead with. With patients who've been on long-term oral corticosteroids, might be a requirement. Patients of chronic asthma, patients who've been uncontrolled might require long-term oral corticosteroids, and there's no other option right now that we can recommend to patients of this category. Always and always stay in touch with your asthmatic patients. I think telemedicine has come up as a very important tool when it comes to patients of chronic diseases like COPD and asthma. So stay in touch with your patient. There is a lot of anxiety. There is a lot of hysteria which is related to not just COVID but the lockdown, prolonged staying inside home. So this is the time when your patient needs your advice, and this is when you can even help the patient in monitoring his or her symptoms on via telemedicine. Make sure that your patient does not stop any medication. That is another thing, that patients often stop their medication when there is no follow up for a very long time. So that is a part that we need to cover. And eventually coming back to nebulizers, so there's a very strong recommendation to avoid nebulization practices completely. Your powdered meter dose inhaler is the drug of choice right now, along with a spacer. And make sure that your patient is not sharing the machine, the spacer, with his family members or anybody else. So I think these are the recommendation when it comes to management of asthma. Yeah, so I think this is a very important question, and I have a lot to talk about when it comes to this specific question. And I'll break it up into three parts. One is your clinical changes that you need to make, mechanical changes that you need to make to your setup, and third is the administrative changes. So first, I'll start with the guidelines that we have. So what any ICU needs is something which is a very strong point of your clinical setup, which is actually outside the ICU, which is your triage room. So basically, you need what we call in our hospital is a COVID corner. A lot of centers are calling it as your fever OPD. So what you need is a designated place where every patient who's coming to your hospital is first undergoing a set of questionnaire, which will then designate the patient into mild, moderate, or severe susceptible for COVID-19. So I think this is something which is outside the ICU, but very much important for your ICU. So you need to first triage your patients into these three subsets, and then eventually when you get your patient into the ICU, so first are all the changes which are related to disinfection, sanitization. As I had mentioned earlier, or as Dr. Arpan said, these were the things that we should have followed all our life. Every time, every respiratory physician should be allotted. I think this is a point which should be made to the hospital administrators, basically, that we should be allotted N95s, irrespective of a COVID era or non-COVID era. So then these are the changes that we need to go through. First is that all your healthcare workers in the ICU need to have proper equipment, that is personal protective equipment. So the PPEs should be there, and everybody should be having an N95 mask. I think it is very easy to say it here while we are sitting in a panel discussion, but the ground reality is very much different. Although we do have an SOP when it comes to the N95 mask. So now what we are following is the SOP that has come from AIMS Delhi, that you can reuse your mask in a cycle of 4 days. So you have mask 1, 2, 3, 4 N95 mask allotted for day 1, day 2, day 3, and day 4, and then you can repeat this mask on day 5 again from the first mask, and this can go for 5 times. So you get to use 4 masks for 20 days. So this is one of the SOPs that is available. PP is, I think, something that we should not compromise on. Disinfection of the surfaces and the area inside the ICU. So thorough cleaning is something I believe was always present with all the ICUs, but now more emphasis is given on how well you are disinfecting your ICUs. Another thing is an administrative change is how many people are you keeping in your ICU. So now what we need is a protocol which relates to the rotational duties, how many people are inside the ICU at a given time, how many hours is a person inside your isolation ward, which is either for a suspect or a confirmed COVID-19 case, and eventually what are the SOPs that you have set for your own hospital, because there is no one size fits all formula over here. According to the resources that we have at our own center, we can go ahead with this. Then we come to machines. So what we are doing, what a lot of centers are doing, is that everybody is keeping a designated machine for the isolation ward. So you have your X-ray machine, your USG machine inside your COVID ward, and you don't take it out to any other ward. So these are the few changes when it comes to clinical changes, and then we come to mechanical changes. So now coming to mechanical changes, I think we've all been through these terminologies, but I'll just put some light on it. First is air circulation. So usually what happens in most of the ICU is there is a recirculatory system. So what your air conditioning system does is it brings air from the outside, brings it inside the ICU, and then it sucks it out and takes it back. So what mechanical change we need here is that we want the air to come inside, but we don't want that air to go back outside to any other part of your hospital. So these are certain changes. I think so they are a bit expensive when it comes for smaller centers to go through these changes. And what the guidelines say is that you need at least 12 air changes per hour with proper HEPA filters. And then coming to the pressure system, so what we've heard again and again and again is a negative pressure system. So in simple words, I'll tell you, a positive pressure system is a room in which you are standing and the air coming inside the room is being pushed out. So nothing can come inside the room from outside. This is your positive pressure. And in the contrary, a negative pressure system is the one in which you are making sure that the infection inside the room is not pushed outside. So what we need here is a negative pressure room. If it is not possible, the recommendations say at least make sure that the exhaust that is coming out of your bronchoscopy room, out of your ICU, is not subjected to another part of your hospital, which might be your waiting area, your OPD area, or the general ward. Just make sure that if you have an exhaust system, the air is now being sent outside the building, preferably a few feet above the height of your building. So these are the mechanical changes, these are the clinical changes. And as I said, on administrative front, we will have to go for rotational duties. Not every person of the team will be entering your ICU. As we all know, we are always obliged to have expert advice from senior consultants, but it is safe for them and for all of us that physicians above the age of 60 do not enter the isolation ward. And when it comes to our regular staff, we have to split them up into rotational duties. So we have to limit the number of people in the ICU ward with the administrative and the mechanical changes. I think we have to face COVID and we have to face a lot of non-COVID also. What we have seen is after the lockdown started opening, so we have had a tide of patients who were kind of who did not come to the hospital for the past 2-3 months. So a lot of asthma, COPD, a lot of lung cancer patients coming with pleural effusion, maybe who are just sitting home for the past 2 months, maybe waiting their time out that one day they'll come to the doctor. So we have a lot of COVID and a lot of non-COVID to attend to in the coming times. We'll have limitations. I believe almost everybody who's used a face shield, you cannot auscultate the patient. A lot of times when you're completely wearing your PPE, you have limitations even with communicating with the patient. So we have limitations of auscultation, maybe advising a PFT, or doing our routine protocol. So this is something new and we will get used to this. And I think the baseline should be that first thing we need to do is protect ourselves. One doctor has the capability of treating at least 1,000 patients in the coming few months. So if we put ourselves at a risk, even if we don't get severely, if we don't succumb to the disease, but we are quarantined or something like that, so that is a big problem. So first we need to protect ourselves.